So this is the Shannon Wong podcast number 5 with Dr. Jane Edmond, who is a pediatric ophthalmologist, actually a pediatric neuro-ophthalmologist, and she's the president-elect of the American Academy of Ophthalmology, and she is the Wong Family Distinguished University Chair at the University of Texas at Austin, in the Department of Ophthalmology at Dell Medical School at the University of Texas at Austin. So welcome to the podcast, Jane.
Thank you, Shannon. Happy and honored to be here.
Great. How would you describe yourself? What would you say you are?
So I started my post-fellowship career as a pediatric ophthalmologist, and the conditions we manage are eye conditions that occur in children, which we have some conditions that adult ophthalmologists do not encounter typically. That is blocked tear duct, lazy eye from early in life, eye turning inward or outward with the vision turning off. That's called amblyopia. In eye misalignments, which are called strabismus, early in life or throughout childhood. Cataracts can occur in children. Cataract extraction in children can be much different than it is in an adult. And also the amblyopia or lazy eye that occurs after the cataract surgery. We manage that with patches to the good eye or drops to the good eye. It's challenging to evaluate young children. Checking their vision is challenging. Checking the prescriptions of their eye is challenging. Pediatric ophthalmologists are trained to assess those conditions and manage parents and engage children enough so that we can get that data, encourage their participation and cooperation, but also to work quickly. We can't get lots of data points like you can in an adult ophthalmology exam. We have to learn to sometimes go with our gut and sometimes go with less than the full complement of information. And it's experiential. Experience of assessing visual acuity or vision in a child that is not reading the eye chart at the end of the room. That takes a lot of experience, just feeling how well they see in clinic, looking at toys, eye contact. So acumen is necessary to take care of children without a lot of data points that you can obtain from an adult. As a pediatric neuro-ophthalmologist, a neuro-ophthalmologist deals with the neurologic disorders that can present in the eye-brain axis. So dealing with optic nerve issues, swelling of the optic nerve, inflammation of the optic nerve, death of the optic nerve. These are things that adult ophthalmologists, comprehensive ophthalmologists, and strictly pediatric ophthalmologists get very uncomfortable dealing with. It's a whole unique area of study that right now is constantly evolving with different genetic mutations that can cause optic nerve injury, different conditions that are on the rise, inflammatory conditions and infectious conditions. So it's a whole different discipline, but as pediatric ophthalmologists, we're responsible for taking care of the whole kid and their whole eye. But when we're deficient of the neurologic aspect of their ocular conditions, that's what's compelled me to do the neuro-ophthalmology piece. So optic nerve conditions, brain-based conditions that influence vision and eye misalignment, that's sort of the separation of general pediatric ophthalmology and neuro-ophthalmology. But as a neuro-ophthalmologist, and a pediatric ophthalmologist, I try to do all of that.
You've achieved a tremendous amount in your lifetime, and I thought it would be very interesting for anybody watching this podcast to learn about your story and how you came to be the person you are today. And so like all stories, I like to start at the beginning. And can you just tell us where you grew up?
I was born in El Paso and spent the first part of my young life there. I have two older brothers. My parents divorced when I was about 2 years of age, and my mom left the house and went to work, first as a social worker. She was fluent in Spanish. She was also a Spanish substitute teacher. And I stayed at home with my niñera, or our maid, who spoke Spanish only, so I did not learn how to speak English till about 3 to 3.5 years of age. I was speaking Spanish. My mother remarried, and my stepfather was in the military, so we moved around a little bit. No overseas tours, but we were in Virginia as he was at the Pentagon, then Fort Sill, Oklahoma, and then back to El Paso on his retirement. So I attended high school in El Paso, and then later went to UT Austin for college.
Okay, so let's go back a little bit. So you're born in El Paso, and your parents divorced at age 2.
Correct.
And then you said your mother and father, what did they do?
My mother and father met in art school at the College of Mines, which is now UTEP. Both were very gifted artists, but my father did not pursue art. He was in the grocery supply marketing business. My stepfather was in the military, retired as a colonel from Fort Sill, Oklahoma, and he and my mother built up a real estate business, which ended up with many thousands of acres in the hill country of Texas, which my stepfather subdivided into lots and brought us back to Texas.
And you are what number in the sequence of 3 children of your parents? Right.
So that I've been very interested in how birth order influences personality. So my brother Mike is 11 years older, and my brother Tim is 7 years older. My brother Mike is a retired neurologist, and my brother Tim is retired from commercial real estate and development of real estate. He lives in Florida. So quite a bit older. I was the only girl. I was the baby, and kind of an only child given that separation, which, as I've gotten interested in how birth order influences children's personalities, I sort of fit some of the phenotype of a lastborn, and that is they're a little bit rebellious, and they think out of the box and seek new experiences, and also parents that are sort of tired of raising children, and so there was less supervision, and I was allowed to maybe have more freedom than my brothers. So that sort of, I think, led me to seek out and celebrate and welcome new experiences like this chair.
Mm-hmm. And then, so your parents separated at age 2, and then you said you were only speaking Spanish for...
Till my mother has informed me that I did not speak English till I was 2 or 3 years of age.
Your parents spoke English with you, right?
Yes, but I hung out all day with Esther, the maid that lived at our house, and she took care of me throughout the day as my mother worked after my parents had gotten a divorce. So I just hung out with Esther, and she did the ironing and took care of our household and made me coffee, which was mainly milk and sugar in the morning. And so I ended up speaking better Spanish than English until around 3.
So it sounds like when your parents separated, you were, your mom was a single mom.
Correct.
Working to support the family.
Correct.
And so she would go off to work, and then it was just you and your brothers at home?
Yeah, well, they were in school.
With the maid or the housekeeper?
Yeah. But me hanging out with our housekeeper.
Okay. And then how long did that continue? When did your mother meet your stepfather?
Yeah, my mother remarried when I was 6, and then we moved away.
Oh, where'd you move to?
We moved to McLean, Virginia. He had a stint at the Pentagon before he went to Vietnam, and he spent 2 terms in Vietnam. During that time, we moved back to El Paso so my mom could be close to my grandparents, her parents. Stayed there another year, and then his final tour of duty was at Fort Sill, Oklahoma, where he was promoted to colonel, and he was in charge of the artillery division.
Did you continue to stay in touch with your dad?
Right, I did not. He had difficulty with paying child support, and his new wife was very opposed to his relationship with his children. And so, from what I understand later in life, she laid down the law that if you keep going to your ex's house every weekend to see your kids, I'm not really interested in being married to you anymore. And so ties were severed.
So you didn't grow up knowing your biological dad?
Maybe seeing him 5 times until I was about 25.
What were those 5 times?
Christmases or holidays in El Paso, when we lived in El Paso, when like during the time that my stepfather was in Vietnam. Maybe a few times when we moved back to El Paso when I entered high school.
Did he keep in touch with your brothers at all, or it was kind of all 3 of y'all were in the same basket?
Yes, exactly, all 3 in the same basket.
And then how do you think that affected you growing up, having the divided family like that?
I was really angry with my biologic father for, 3 decades, first 3 decades of my life, that he had neglected us. He willfully stopped paying child support and was more devoted to his new family. But I found out about a year before he died, when my oldest brother, felt the need to reconnect with our father. And he went back to visit him in El Paso and sort of found out a different story than what my mother had portrayed to us, that he had wanted to, he didn't want to support us, he didn't want to send child support, when actually my mom told him to stop sending child support, and was more interested in us separating away from him. And also, upon their divorce, my mom kicked him out. She wanted a new life. She had gotten married at the age of 17 to my father, and 18 years, 19 years went by. She decided this is not the man for me, and basically turned him out of the house. We never knew that. And that sort of story, that he'd been sidelined by my mom, made me much more forgiving of not having had him around, and understanding now as an adult with my own children, my own life, and my own husband. That backstory led me to 100% forgiveness.
What was it like growing? So you grew up, you started out in El Paso, then you moved to Virginia. You were there for how long?
1 year.
Oh, and then you moved back to El Paso.
For another year while he was in Vietnam, right.
And you went to high school in El Paso?
Correct. 1 year of middle school, I guess, 8th grade, and then high school.
What was high school Jane like?
I wasn't the greatest, it was a huge public high school, Coronado High School. I think there were 700 in my class. It was on the west side of town, a very wide demographic of student from all kinds of backgrounds, many with English as their second language. I wasn't my parents were very hands-off, didn't care if I studied or skipped school, not that I skipped school, but very little oversight into academics. So I was a middling sort of student. I think my average was 86 or something, and I was 130 in my class of 700. But I was very interested in the sciences, very inspired by my science teacher, Mr. Ray, I was also the best of my two siblings, and I was the best artist. So I pursued that, took a lot of art classes in high school, and worked every summer for artists, cleaning paint brushes and doing tasks for artists. And I got involved with the yearbook. I was the yearbook, designed the yearbook cover my senior year, which actually Jostin stole and repurposed my yearbook cover. Of course, no one got any, there was no intellectual property or patents, so the school, I'm sure, did not make any money from our design. Instead of going into modern dance, I picked up fencing at the local Y. My mom was always annoyed about having to drive me all the way downtown for my fencing lessons and tournaments. So I was not the greatest student, not the most studious. It just sort of came naturally, being a B student, and my academics really turned on when I got to college.
So you did artistic things in high school? You were kind of like a middle-of-the-road student?
86 average, I think, is what I was in, maybe 130 in the class. What was your thought process as to what you would do after high school at that point? So my goal was to become a medical illustrator. And if you can remember way back, medical illustrators, there were no digital arts. So artists drew and painted images for textbooks. And there was a very famous medical illustrator named Frank Netter. And he created a series of illustrated books in disease topics like the central nervous system and the GI system and the reproductive system. And those were the gifts my brother Mike, who was became a neurologist, those were Christmas gifts to me. And since I was very interested in art and science, this was like a perfect blending of those two disciplines. So when I went to UT Austin, that was my intention, was to become a medical illustrator.
So your initial major at UT Austin was what?
My major was always biology, but I was taking life drawing classes. These are the entry classes into art at UT, maybe other schools. So I was in life drawing for 1.5 years. And it was then that I discovered that I was not such a hotshot artist. In a class with really very gifted art students, I was not even the middle of the road. I was not inspired. I was not innovative. I was pursuing a career as a draftsman. And that just it felt suboptimal, not reaching my highest potential. Becoming a draftsman when I'm exposed to all these amazing art students felt inferior and not the path I wanted to take. And I didn't want to be somebody that was not at the top of their game or able to excel in my field. And I felt, comparing myself to these other students, I'd never be as good as they.
You realized this during your freshman year?
Freshman and sophomore year, yes.
So then, looking back, what was going through your mind? How were you going to navigate? So
my brother had done 2 residencies, internal medicine and neurology, and he was a practicing neurologist.
While you were a college student?
Yeah, actually, that's correct. He was doing his neurology internal medicine residency in San Antonio. And he lived outside of San Antonio with his wife, who was infectious disease. She was a clinician scientist in pediatric infectious disease. And brother Mike was inspirational to me to pursue medicine, but it's mainly my sister-in-law, Betty Edmond.
That's his wife.
That's his wife.
Mm-hmm.
And she is about 10 years older than myself. She went to UT Southwest. Out of the class of 200, she was one of 16 women. And that was you know, in those days, you know, men were doctors and women were nurses. So it was breaking through those barriers, and she was quite a pioneer in that way. I felt that my generation, we were also pioneers in that way. At Baylor, our class size was about 165, and there were 24 women. So she was very, you know, led the way for me, inspiration to me to pursue medicine, that I could do that women can do that, that we could become professionals. We didn't have to just break through expectations my mother had, which was you should marry a doctor and not be one.
What activities did you get involved with at UT, and how was your UT experience?
I had a lot of fun in high school. I was senior favorite, I was basketball sweetheart, I was wrestling sweetheart, and when I got to college, I just...
Does that mean you played those things, or you were just... what does that mean?
It's like, oh gosh, like, you know, the rah-rah girl who attends all the games. I like made a gajillion posters for the wrestling team and the basketball team, and you know, we got a big layout in the yearbook. Senior favorite was a great position to be elected to. That was the most...
What is that?
A senior favorite is there's always a boy and a girl chosen to represent the class as the favorite in the class.
Oh, nice.
Yeah, it was very nice.
Okay, so your activities that you were doing.
I turned it on in college. So I pledged a sorority because my mother was so insistent. You know, she's still thinking in this path that there was no professional life for you, or no expectations for that, or no guidance or support for that. So, you know, get married to a doctor, join junior league, you know, do philanthropic things, raise, you know, batch of kids, you know, a similar life that she had led. So when I got to college, I did pledge to her, much to her insistence, and was surrounded in those days.
Was this as a freshman or sophomore?
As a freshman.
Which sorority?
I was a Delta Gamma. And not many women at that time, very much unlike sororities at this time, not many women were pursuing professional pathways. There were a lot of brides magazines sitting around and people talking about what their wedding dress might look like, and they were, I don't know if you've ever heard this, but MRS degree.
Sure.
Lots of the women in my sorority, which was huge, pursuing an MRS degree. So I went on some dates, match dates set up with fraternity brothers because of my being a pledge with Delta Gamma. And I rapidly figured out that the party scene was not fulfilling, and that I just flipped a switch and did complete academic pursuits. So stopped getting set up on match dates, which were very disappointing. I do remember you invited me in my first year as chair to pre-COVID to a UT Iowa State football game, and we got to sit in the president's box, and Big Bertha was banging all the time because we were like killing them, and the cannons going off, and the Cowboys out there, and the Spurs, and cheerleaders everywhere. The one game previous to that football game I had attended was with a drunk frat rat. We were on the sunny side of the stadium. I was broiling. All this guy was doing was talking with his frat rat pals. I was not at all, I was his date, but completely ignored. It was like such a dichotomy and difference in experiences. But after a few dates like that, forget it. I am not pursuing the social life here.
So in college, you didn't have any long-term boyfriends or anything like that?
I had a boyfriend. I'd met him in El Paso, and he was attending law school at UT. So that also helped me eliminate those social distractions, which I felt were distractions. I really didn't make the most of college co-ed life in terms of all the fun, cool, awesome activities UT has to offer and Austin had to offer at the time, because I just focused pretty much exclusively on getting into med school.
Looking back, would you want to go through that same experience, or would you do it differently if you had to do it again?
I would probably, if I had to do it again, I think I could have still gotten into medical school, but I felt I was so late to the studious game. I'd been kind of this, floating through high school, making decent grades, not really without much effort. I could have probably still brought in a social agenda, but I did feel like I didn't know how to study. I didn't know how to write a paragraph. I was just way behind the 8 ball, and I needed to expend extra effort and energy catching up, really.
And you graduated in 4 years, 3 years?
4 years.
And did you ever get a B in your college career?
Oh, gosh. Yes. Math was my nemesis. So you remember the pre-med requirements and the legislative requirements at the time. I signed up for algebra, and that clearly it was like speaking Martian. So I dropped out of that, got into pre-algebra, and still it was rough. And I made a C. That was my first semester of college.
Because you graduated, I believe you graduated summa cum laude from UT, right?
I graduated with high honors and Phi Beta Kappa.
But you got 1 C.
I got 1 C.
Well, we actually have that in common, because math is my worst subject.
Oh.
And I will admit I got a C in calculus. If I had to take anything more than calculus, I would have never made it. All right. So you're in college, and your brother and sister-in-law have kind of introduced to you this concept of, hey, maybe you could go into medical school. So then when did you start kind of dialing in, hey, maybe I should apply? And then where did you apply, and how did you end up where you ended up going? So
in those days, we had to handwrite every application in a little tiny space. It had to be no typos, had to be perfect penmanship. I guess some people typed on their manual typewriter, but I did handwrite mine. And I applied to all the Texas schools. The UT system, and then Baylor was semi-private. And at the time, I think A&M was brand new, Texas Tech was brand new. I don't think I applied to Tech because it had just opened and was not a known entity, and what the experience would be like there. And I'd have to rotate in El Paso, a place I really didn't want to go back to. So applied to the UT Southwest, UT San Antonio, UT Houston, Galveston, and Baylor.
And you ended up going to Baylor.
I did. I did not match right away at Baylor. I matched at UT San Antonio. I was very happy about that. UT Houston, happy about that, but really wanted to attend Baylor. And I matched there probably after 3 letters have gone out, and then students accept or don't, and then they go down. It's like a rolling admission, I imagine, at that time. Maybe it is still that way. And jumped at the chance to attend Baylor.
Oh, wow. Okay, so you graduated from UT Austin what year?
I graduated in 1981.
Okay, and then you're off to Houston, Texas, Baylor College of Medicine. How did that? How was that experience?
The experience at Baylor?
Yes.
It was incredible. I was a nervous student. I didn't. While I was friendly, I had a close set of colleagues to whom I would ask, "How'd you do on biochemistry?" or "How'd you do on pharmacology?" Because people like to brag and talk about their, what great grades, and that just made me feel badly that I wasn't working hard enough or smart enough. I just sort of kept my nose to the grindstone and my close friend set that we supported each other. But it was, I remember the first day, well, the weekend that I interviewed at Baylor. We went from the main building through a tunnel into the ER at Ben Taub, and it was Saturday morning, so it was filled with a lot of knife and gun club, intoxicated people, other people who were sick. They were spilling out into the hallways, and that was such a memorable and sentinel moment for me that convinced me that healthcare, helping people, being in a medical school and the medical profession was just absolutely the most wonderful thing to aspire to, and very honored to get into Baylor.
And there's still about 165, 168 students each year?
I think so. I'm not sure.
And what percent were women at,
in my
in your class?
It was about 165 when I went to Baylor, and 24 were women. Since we're both not at ease with math, I don't know the percentage on that.
So Baylor.
And today, all med schools are over 50% women.
Right. Thoughts on your experience at Baylor College of Medicine? What was your, what memories do you stay with you?
So it was the traditional 2 years of didactics, butt numbing, sitting in a lecture hall, etc. And I think I made a few honors at the time in the basic sciences, but it was really the clinical, and as I'm certain most students feel this way, that it was the clinical experience that this is why I want to be a doctor, is to be with patients and other physicians and working in the inpatient, outpatient experience. And I remember I graduated AOA, which is Alpha Omega Alpha, which is Medical Honors Society, and that was due to having made honors in all of my core and elective clerkships. So after the didactic session, the 2 years of patient care and being on the wards or in the hospital outpatient, that's where I made my best grades, and that's how I graduated with this in the Honor Society. And I remember seeing the residents who were managing the inpatient service at the county hospital or the VA, and seeing all the tasks that needed to be accomplished, and we maybe the blood drawing person hadn't come that morning, or we hadn't gotten the information about the lab testing that was done, or the radiology tech hadn't picked up our patient for imaging, that it was all hands on deck. And to stand back and not participate, and to, I just dove in, like, how can I help my team? We are a team. We're working toward one goal, and how can I help you? How can I help our team get home at less than 7 o'clock at night? How can I help our team take care of patients? So I got to the hospital early. I did like a pre-rounds on my patients, had my notes ready, which I prepared for the resident, my note in the chart, so that then when the attending came and the resident had to present, they had my notes. I think that's what garnered my good grades in those experiences and those rotations, was my seeing what needed to be done and helping out as a team player.
You would get there before the whole team?
Yes.
So what kind of time, if you could remember that?
Yeah, unfortunately I do, from OB-GYN. So the resident got there at 7, and the intern got there at 6:30, so I would get there a little bit before 6 o'clock in the morning.
And you would be the first person to see all the patients?
My patients, so the patients that were assigned to me. And I was assigned to an intern, who was assigned to a resident.
Were many other students doing that?
Gosh, I don't really, it's thousands of years ago. I think dinosaurs were roaming the earth, so I'm not entirely sure.
Yeah, no, I think it's a pro tip if somebody's listening. I think that's good advice to get ahead in life, period. You're in medical school, and then you could go into anything. You could become a psychiatrist or a cardiothoracic surgeon, because that's the Baylor way. How did you? What was your process of selecting a future residency?
So I talked to my brother, who was internal medicine and neurology trained, and my sister-in-law, pediatric trained, and then ID, infectious disease. And my brother Mike sort of outlined what he thought would be specialties that I would flourish in, specialties he sort of wished he had pursued. And that was a blend of clinical care and surgical care, not being solely in the operating room like a general surgeon, and not being solely in the clinical space like internal medicine neurology. And proposed to me that there would be better work-life balance if you had pursued in radiology or dermatology or ophthalmology. So I did rotations and otolaryngology, ENT. So I did rotations in all of those, electives in those areas. But what turned me on was ophthalmology. And what compelled me into ophthalmology, I think, in the very beginning, was the residents. I just found that the residents in ophthalmology were diverse. They had other experiences, and some were artists, some were musicians on the side. They were a diverse group, and it's a very selective field and difficult to get into ophthalmology in a residency. So they were very bright, very intelligent. I just liked hanging out with them better than I liked hanging out with the other residents on other services. So I think that was my first entree into ophthalmology, but I also, much beyond that, could see that it was a terrific blend and balance of being in the clinic and being in the operating room. The eye is such a beautiful organ, and coming from an art background, and how important vision is to my previous desire of becoming an artist and a medical illustrator, and my parents having been artists, I think there was a synergy there. The longitudinal care for over a lifetime. So ophthalmologists take care of preterm born babies, premature babies to the end of life. We have a longitudinal experience with our patients, unlike some surgical specialties where it's one and done. You do the surgery and goodbye. We take care of our patients even after, post-operatively. They're ours. Very exacting microsurgery. I also was compelled by that. I was very good with my hands. So those were the things that attracted me to ophthalmology, and frankly, how difficult it was to become an ophthalmologist. A bar set high. I tended to push myself to achieve goals that may be seemingly out of reach to some, but that also put a fire under me that it was hard to get into ophthalmology.
So you're a middle of the road high school student, and then you seemingly kind of turn it on. How did you learn what you were capable of? What was the process like?
Graduating with high honors from UT, being Phi Beta Kappa, getting into medical school, that helped my imposter syndrome, for me to realize that, yes, if you work hard, push yourself, you are capable of these things when you never had that expectation and your parents had no expectations for you. So that helped me instill confidence in me, didn't fill me up by any means. I have always strived for more, to be better, to do more, to achieve a higher level.
So do you think your ability was getting more in medical school, even like it's almost like you're tapping your potential? Do you think that you were getting it's almost like a professional athlete? You were getting better and better, like academically, cognitively throughout this process from high school, college, medical school?
I would say that is correct. Learning how to study, learning how to care for patients, learning how to process data, all of that gets refined actually in medicine over a lifetime. I mean, I learn something new for my patients every time I'm in clinic.
Did you learn like systems of, a pattern, a system that you figured out along the way of how to become more efficient, more capable? Because there are a lot of people who, they're like you. They're untapped potential when they're younger, but then they kind of hit their stride, and then they get in gear as they get older. Did you?
I think for me, what is a differentiator is curiosity. So patients come to us and present with unusual symptoms. It doesn't, fit into a tidy diagnosis, or they have an underlying condition that I've never heard of. I'm naturally curious, so that I go back and I study those conditions or research those conditions or reach out to other colleagues who may be specialists in that area, whether they be in ophthalmology or outside of ophthalmology. I think that has helped me become the physician that I am. That scientific curiosity. I'm not just at work to plow through 30 patients a day. That every patient, many patients are like, you have to be a detective to determine what is the issue and their problem and how to solve it.
So now we're in medical school, and we're realizing that we want to go into ophthalmology. And then how did you end up matching in ophthalmology? How was that? What was that process like? What was the ophthalmology residency application process like, and how did you end up where you went for residency? So
I was married in medical school, my third year, and my husband Randy Weber was otolaryngologist, and he was pursuing head and neck surgery and had just finished his fellowship at MD Anderson in Houston, Texas. So as I was applying for residency, it was would be terrific if I could stay in Houston. However, I did not want to limit myself, and applied more broadly. So I applied to Baylor College of Medicine. I applied to UT Southwestern. I applied to some schools across the country. He also had an opportunity to pursue head and neck surgery at Sloan Kettering, so I applied to some New York programs. And again, it was a handwritten, not a standardized application.
You didn't even type on the application. You just wrote it by hand.
I think that there was so little space that I felt that I would limit myself if I used a typewriter. So I had tried to use my best penmanship in the tiniest legible font.
And this is before, I don't think back in that time that they had erasable pens.
Correct. We had whiteout though.
Oh yeah, that's true. So you ended up going to Baylor College of Medicine for ophthalmology residency.
Matched at Baylor. So there was SF Match, like there is today, and somehow magically, everyone got their letter on the same day. Like if you lived on either coast, you got the letter on the same day of your match results. Well, I had been on call the night before. I'd forgotten what service I was on, and I had to do the cleanup work of all the patients that had been admitted the night before with my team. And so I did not get home to my mailbox until about 6 or 7 that night. But I'd been hearing from friends, and there was a landmark bumper crop of students from Baylor that year matching into ophthalmology. I think there were like maybe 15 out of a class of 165. It was an impossibly high number, making the competition even more stiff. So I'd heard from running into people at Ben Taub or wherever I was rotating at the time that they'd gotten their letter, they'd heard, and so I picked up the phone and called SF Match. They answered the phone in the days when people actually answered the phone, and asked where I had matched. And I guess I'd remembered my SF Match number, and they told me I matched at Baylor College of Medicine. And I, for many reasons, I was overjoyed. My top choice, it was my number 1 on my match list. But I got so nervous that maybe they misread my application. Maybe they read where I went to med school, where I was going to med school, and they didn't bump down to where I matched. So I called them back. Are you sure? So I got my letter later that night, and the rest is history, I guess.
Where did you do your intern year?
Oh, so the internship year was separated, unlike it is today. The internship year, you had to go through ERAS, which is another match system, a national, I've forgotten what ERAS stands for, I should know. But it's another matching program that matches all the other subspecialties besides ophthalmology and plastic surgery, I believe, or urology. SF Match oversees those few match processes. So I had to go through another match process, and I had the Baylor and UT Houston. There were a lot of internships. You could do an internship in surgery or internal medicine, or you could do we call them prelim years, transitional year program, which was that was a desirable internship for those pursuing ophthalmology. It was sort of fluffy, though, in my opinion. You could take not very difficult or easy street sort of rotations that you got home at 4 o'clock and you didn't have to take call. But in my opinion, it did not create a whole doctor. And in ophthalmology, we take care of a lot of systemic diseases that present in the eye. And I thought it was just cheesing out to do a fluffy prelim year as an intern. So I matched into an internal medicine prelim year that was offered through St. Luke's. So I spent half my time at St. Luke's on internal medicine subspecialty rotations, and the other half of the time either at Ben Taub, our county hospital, or at the VA.
Mm-hmm, mm-hmm. And then you started ophthalmology residency, and what was that experience like at Baylor?
Yeah, it was amazing. Our chair, Danny Jones, is and was one of the smartest people I've ever met, and set the bar very high. And we all knew when he was disappointed in your performance at Grand Rounds. So we'd be on the hot seat every week, Friday morning. We would have the first hour, 8 to 9, patient examinations. There would be up to from 4 to 6 patients that we would read their histories on the door leading into the exam room, and then we'd be able to examine them with the equipment in the exam room, ask them questions, and then go to the next patient. And then Danny Jones, the chair, would call on residents. What do you think about Mrs. X? What do you think the differential diagnosis is? Or give me a list for her potential diagnoses for the problem that you saw. What did you see on your exam? And what is the differential or the list of possible diagnoses? And then what is your leading diagnosis? How are you going to manage that? And In those days, we didn't have our phones to like Google anything. We had a library next door where we'd rapidly go back and research some rare condition and try to find the textbook and beat out your other resident to that textbook. We also carried in our pockets we called them peripheral brain, and these were note cards in which we had written out information that we would now get off of our phone, like what are the top 5 causes of this certain cornea condition that presents in the epithelium, or what are the top 8 causes of conjunctivitis or eye redness in a neonate. So these cards were also handwritten in microscopic font so that we wouldn't look like idiots when we were in grand rounds, getting pimped, which is what we called the quizzing process, by our chair. They also helped us in clinic because if we had a child with conjunctivitis, we had our peripheral brain, and these are the top 8 causes that we need to consider when assessing this child. So without a computer and without your phone to connect to the Wi-Fi, that's how we that helped educate us and helped us take care of patients.
So that was obviously very memorable. Do you think that you'll do that for your current program?
Oh, no, it's called harassment.
Oh, it is?
Oh, definitely. So that kind of, so that method is called the Socratic method of, so Shannon, what do you think, what did you find on the exam of your patient, and what do you think the diagnosis might be? Give it the list with your leading diagnosis. That in some medical schools has been medical students on their reviews of their experience, probably conducted by the ACGME, or the Association of Medical Colleges, American Association of Medical Colleges. These medical schools get dinged and cited for harassment. So we have to scale it back. So scaled back, but not wholly diluted, because this is actually how we train residents to think and to think through a problem. So what did you see in the exam? And help them get rid of the extraneous features of the exam and drill down and focus on what exactly is the problem at hand and how to pick through the diagnosis, differential, and management treatment pathway. So we don't do it in an impugning way, in a threatening way, and in a way that makes you feel like you're being judged as a learner, more gently guiding you through a kinder Socratic method.
So back in the day, when you were a resident, I was basically a medical student, and I experienced, while I was doing the ophthalmology rotation at Baylor, what you're trying to describe. I thought it was an outstanding teaching experience, and I think that I'm kind of disheartened to hear that that's considered harassment in this day and age.
Well, by some students, it is considered harassment, but I too feel, so I was, those experiences make you uncomfortable, but that discomfort led me to achieve a higher level. So when I was a fellow, I know we haven't talked about my fellowship, but I had a mentor that was very much in that same teaching style, and there was not just a look of disappointment, but the verbal, you should know that. And the next time I ask you, I want to hear a more succinct and accurate differential or assessment or treatment plan. And the next time, there was no next time that I messed up on that diagnosis or that paper that I should have memorized the findings in that paper so that I could apply it to my evidence-based medicine practice. So it was uncomfortable, but it made me a better doctor.
Yeah, I think holding people to very high standards if it makes them uncomfortable, it makes them better. And if you always want to make people feel comfortable, then there is a certain tolerance of mediocrity.
Correct.
And I'm not in love with that. So if I want to see a doctor and I want to go see the best doctor, I want to go see somebody who I know who has been tested by fire to be excellent, rather than somebody who was always given the niceties so their feelings wouldn't be hurt.
Right. And we also want to choose physicians in my department and choose residents that are motivated, self-motivated. So that also, that and a Socratic method that may be a little bit kinder, I think can result in the same excellent, thoughtful physician who is self-critical and always trying to achieve better outcomes, do better by their patients.
Things change, I understand. So ophthalmology residency is 3 years, and then at what point during that process did you think to yourself, oh, I think I want to, or at what point did you consider pediatric ophthalmology, or what was the process by which you ended up choosing that career path?
So sitting in grand rounds, all of the attendings or the senior doctors that we worked with attended, and Dr. Gunter Van Orden was the chief of the pediatric ophthalmology service at Texas Children's at the time. And when a pediatric ophthalmology problem was presented, specifically an eye misalignment issue, a patient came in with that's called strabismus, eye misalignment. And we would go in the room and assess the eye alignment. But when Dr. Van Orden would speak about the patient in the meeting after the patient exams, so brilliant. And everyone was in such awe of how he processed through these complicated eye misalignment situations and patients. We have 6 eye muscles per eye. We have 9 different gaze positions or places our eyes move. All those 6 muscles have differential actions and differential gaze positions, but he could process complicated ocular misalignments seemingly in minutes, leaving everyone dumbstruck as to how he did that. And I'm like, I'll never be that smart, but at least I can aspire to that. So he was really my inspiration to pursue pediatric ophthalmology.
And did he stayed at Baylor throughout his tenure? That's
correct. He retired, I believe, in 1995 from clinical practice.
Mm-hmm, mm-hmm. How did you end up choosing the University of Iowa for your pediatric ophthalmology and strabismus fellowship?
So there were maybe 8 top pediatric ophthalmology and strabismus fellowships, Iowa being one, Baylor being one, University of Indiana University being one, Washington D.C. Children's, Bascom Palmer in Miami. So in those days, there was no Zoom interviews, so you had to leave your clinical service and get permission to leave your service in your 3rd year of residency to go do your interviews. So you couldn't interview everywhere. You had to be selective. So those were the schools that I obtained interviews. And I wanted to leave Baylor, even though I was married and my husband had a job at MD Anderson and was rising the academic ladder there. I wanted a different experience. So it was fortunate that Dr. Van Orden was also wanting to match his first fellow's son-in-law, so that spot was already sort of taken. So that also gave me a good excuse to not pursue matching at Baylor. So I interviewed at Iowa and felt the culture there was terrific. It was a amazing top ophthalmology department globally, not just the fellowship in peds, but every single department and division within the University of Iowa Department of Ophthalmology was outstanding. I just wanted a great experience in their grand rounds. I wanted to learn from the retina docs. I was having to take my boards. They had grand rounds every morning. There was no children's hospital, so the pediatric ophthalmologist, that clinic was embedded with the other services, retina, neuro-ophthalmology, and I wanted a global, excellent academic experience, not just in pediatric ophthalmology. So I matched at Iowa.
And it's a 2-year fellowship?
1 year.
1 year fellowship.
Right. Most pediatric ophthalmology fellowships are 1 year.
And along the way, you said in passing that you met your husband, Randy, when you were in medical school?
Correct.
What year in medical school?
We met when I was a sophomore and married when I was a junior. Or my second year we met, and in my third year we got married.
Okay. How did you guys meet?
We met in the Ben Taub emergency room. And at that time, it was divided to medicine side and surgery side. And I think he'd spied me on the wards because I was doing a rotation in medicine, and I was maybe in the ER rotation. And he had heard me speaking Spanish, came over to the medicine side and asked if I could translate for him on a Spanish-speaking patient that he was caring for on the surgery side. Asked me on a date, and there you go.
Are you fluent in Spanish to this day?
No, it is. It's mainly Spanglish, and I was much better as a resident because I was speaking Spanish a lot. I was much more at ease speaking Spanish in Houston, where my 40% of my patients seem to be Spanish-speaking only. I guess the demographic here in Austin is different. There are much fewer Hispanic patients in my clinic today at Dell Children's.
Mm-hmm, mm-hmm, mm-hmm. How did you guys navigate sounds like he's in one location while you're doing your training in a different location.
Correct. So for my fellowship year, I left for Iowa. I would return back to Houston every 3 weeks or so. It was a bit complicated because there are no direct flights out of Cedar Rapids, and there's no airport in Iowa City. But it was not, unless there was a blizzard, it was not that difficult. I would stay to Sunday evening and then come back home. And it was actually a great year. I'd never lived alone in my entire life. I'd always had roommates. And that year, I took both boards, my written board and the oral boards for ophthalmology. So I knocked those out of the way. I could eat popcorn for dinner and study all weekend. And it was pretty much a joy to study because I just loved pediatric ophthalmology. And the community there, it was not like the experience I had at Baylor at the time, where faculty are here and the residents are over here and fellows. There was a palpable schism between faculty and the trainees. At Iowa, maybe because it's a smaller community, faculty would invite me over for dinner, residents over for dinner. Dr. Fred Bloody, a very famous former chair at Iowa, actually lived a couple blocks away from me. I rented a house from 2 PhDs that were out on sabbatical from the University of Iowa, and he lives a couple blocks away. He would have poker night, and all the residents would attend, and the fellows. It was just like, wow, an attending doctor wants to hang out with us. It was super cool. So I loved the culture there, very cohesive and friendly and not so hierarchical. And I got to study pediatric ophthalmology and pass my boards, and it was a great experience. And for my husband, he got a lot of papers published.
He was working where at the time?
MD Anderson in Houston. So it flew by, and It was a terrific year.
Now, at what point did the two of you start having kids?
So at that time, when I came back from my fellowship and got a job at Baylor in the department as a pediatric ophthalmologist, I was 30 to 31. So time to, that biologic clock is ticking. My eggs are 30 years old plus 9 months. We wanted a family, so I did not want to be pregnant as a trainee. You don't know if you're going to go to bed rest. I didn't want anything to detract from these rich, limited experiences of my education. So wanted to start my family after that was over. So when I got back home, back to Houston, that's when I got pregnant with my first child, Austin Weber, and then about 19 months later had my daughter, Sophie Weber.
You finish your fellowship, then what was your thought process?
My husband, Randy, was at MD Anderson. His career was going really well. I started to look for jobs in Houston. Obviously, that's going to work out better for my husband. There was no intention of hiring a pediatric ophthalmologist at Baylor. I looked at a private practice opportunity that didn't feel very good. We also entertained, after maybe I got back to town and had a private practice job, we would both seek academic jobs together, maybe in New York, where Memorial Sloan Kettering, or other academic institutions, but it was just too much to figure out during my fellowship. So probably going to take this private practice position, but not feeling good about it. So I probably 3 months before the end of my fellowship, we had beepers at the time, and I got a page, and the telephone number to call was Danny Jones's office. So of course I still remember that telephone number, and I'm thinking I must be in the worst trouble, that he is calling me in my fellowship. I haven't been in Houston in over a year. So I very nervously call back. His secretary, his longtime assistant, Dora, picks up the phone. Hi, Dora. Dr. Jones is calling me. Well, Dr. Jones, Danny Jones, was calling me because Paul Steinkuller, the second pediatric ophthalmologist who worked with Dr. Van Noorden, had been called up to active duty via the National Guards for the Gulf War. And he was going to be gone from Houston and Texas Children's for an untold number of months. And Dr. Van Noorden was not excited about retinopathy of prematurity nursery rounds, not excited about taking care of consults in the hospital, or pink eye that came in from urgent referrals. And would I come back to Baylor and Texas Children's and help without any promises of a job? But this is going to be a temporary gig waiting for Dr. Steinkuller to come back, another very cherished colleague of mine and mentor. So I basically jumped at the chance. So I turned down the private practice job, not knowing at all and not expecting the Baylor position to work out. But I wanted to give back. I wanted to be with my people at Baylor and enjoy that experience for as long as it lasted, and I'd figure out something afterward. So back at Baylor, working with Dr. Van Noorden, taking care of all the conditions he wasn't comfortable caring for, or which also detracted from writing the third edition of his textbook, which is on the shelf of every pediatric ophthalmologist office bookshelf. After about 3 to 4 months there, Danny Jones and Gunter Van Noorden offered me a position. So that was my start into academics, was by just taking a leap for an opportunity that I didn't know would pan out.
And then when Dr. Steinkuhler came back, I assume he came back,
He
right?
did.
Then what happened?
I had already been given. Was not. He was not active in the war. He was actually in Pensacola, Florida, doing pap smears and playing golf half the day, I think. So it wasn't a really rigorous gig. He came back maybe 6 months after I'd been back at Baylor, so he rejoined the faculty, rejoined his position.
And they offered you a more permanent position, I
Yeah, before he came back, they offered me a permanent position.
Okay.
Things were working out very well.
And then you continued as a pediatric academic and clinical pediatric ophthalmologist, Baylor College of Medicine. From when until when?
From 1991, I joined the faculty in 1991. That's when my fellowship ended, was in 1990. And then I stayed at Baylor and Texas Children's till 1996. And at that time, my husband was interested in pursuing his dream of becoming the chair of a Department of Otolaryngology, or ENT. And he felt that staying at MD Anderson was not going to give him the experience in a general ENT department. He would not have the experiences he needed to become a chair. And at that time, so he wanted to interview and leave Houston and join an academic department. And at that time, I also, I've been at Baylor my entire adult professional life, medical school, internship. I went away for my fellowship, but then coming back. So I too wanted a change of scenery and a different experience. So my husband was offered a position as vice chair of the ENT department at the University of Pennsylvania, Hospital of the University of Pennsylvania. And I interviewed for jobs in the Philadelphia area and in Delaware.
This is 1996.
1996.
Mm-hmm.
And I had the opportunity to join another division of the University of Pennsylvania, the ophthalmology department, but the pediatric ophthalmology division, which was housed in the Children's Hospital of Philadelphia, goes by the name of CHOP. I also was offered a volunteer position at Wills Eye Hospital, the famous leading eye institute in the United States, and that was a Friday clinic where I taught residents, oversaw a residence clinic and resident surgery, and that was on a Friday, and all of those were amazing, terrific experiences.
And so you're basically full-time at CHOP, and you're kind of like part-time at Wills. Is that correct?
Actually, I was part-time at CHOP as well.
Mm-hmm.
And what part-time meant is on 2 afternoons a week, I got to pick my kids up from school at 2:30. Mm-hmm. And we would go to the Bryn Mawr Library and we would read books, or we would go to Ruby Tuesdays and get a milkshake, or we would go play with friends on a playground. So I had 2 afternoons to do that. So it was actually considered part-time work.
How old were your kids when you were in Philadelphia?
We moved to Philly when Austin was 5 and Sophie was 3. And we spent 7 years there.
Good times.
Yeah, they were great times.
So, CHOP, Scheie, Wills, 7 years in Philadelphia, in that area, right?
Correct.
And so how was Randy doing with University of Pennsylvania ENT?
It was a very busy time for him. He would come home, he would work 15-hour days routinely. My kids did not see him at dinner. He had 2 OR days a week, operating room days. One was on a Friday. He would start an elective case at 10 p.m., elective thyroid. After about a year and a half of that, he had serious conversation with the chair, and he was given a second room so he could actually come home more around 9 o'clock instead of 2 a.m. when he nearly fell asleep driving on Schuylkill home. But it was a very productive time for him, and the University of Pennsylvania is an amazing place to be. Offered a lot of chairs by the end of that 7 years, so he was fulfilling his professional dreams and goals. He interviewed it for several chair positions of otolaryngology or ENT, but his dream job was MD Anderson. He wanted to go back to MD Anderson and not lead a department of all the specialties of ENT. And that happened after that, at about the 7-year mark. And I was very reluctant and unhappy to leave Philadelphia. My kids were in a great school. I loved our neighborhood. I loved being at Will's and CHOP. It was very fulfilling for me professionally. But at around that time, that exact time that Randy was offered the position, we got a call that my mother's husband at the time was diagnosed with pancreatic cancer. And he was dead in 4 months after that. And I knew at his diagnosis, it happened like 2 days separated from when Randy was offered the job at MD Anderson, that it was God telling me to go home. And I called Danny Jones, Dr. Jones at the time, and thankfully I got my old job back. And that's very difficult. Now as a chair, I know how difficult that is to do at a budget cycle. So I'm very grateful for, I know all the hard work that goes into hiring anybody out of budget.
Any thoughts on or advice for women in medicine these days who are trying to balance work and family?
So I have told I've advised young ophthalmologists in academics, and I presume this would also apply to those in private practice, is that there's a time and place in your life for where you're going to spend more energy focusing on your children and maybe less on your career development, but never give up on either. So for me, when I moved to Philadelphia, I made a conscious choice to scale back my academic productivity to be with my kids. So those 2 days a week, I got to pick them up, and I didn't spend all weekend, editing and writing papers and fiddling around with electronic health records. And I felt badly about that. And I felt guilty that my career was sort of stalled. It was still on a trajectory of improvement and an upward trajectory, but not at the same, rate that it would have been if I had worked full-time and sidelined care of my children and spending time with my children, if I had not made that up, if that was less of a priority, my career being a number one priority. And I felt badly. I felt badly for the entire 10 years that I did that. So my advice to women that are younger than me, that are in that situation, is please do not feel guilty. There's a time in your career. Stick with it. Do the kid thing. You never want to feel that you didn't give the most and the best to your children. And you can always ramp up your career later. Never give up on your time in medicine, your career in medicine, but you can put it on fire after they go to college. When they're in high school and they don't get home till 7, that's when you turn it up.
I agree. So then you want to go down that road at all more, or is that pretty good? Because I think that's a big topic, the work-life balance thing, the
I can go
motherhood.
Yeah, I can do more on that.
You want to? Go ahead.
So I also raising my family, career in medicine, I wasn't delegating enough. That's another tip I have for young women in medicine who have families, and that is, you don't need to make dinner every night. Do not make dinner every night. Delegate out that task. Delegate, delegate out task, period. So determine what is less of a priority for what you're doing for the household, and the things that you don't like to do, things that take away time from spending time with your family and picking your kids up or being with your children. And hire out. Like, I had a whole village of employees helping me run my household and allowing me to give my best to my family. So I've had some terrible nannies. I have a recipe on how to choose the best nanny. We had some terrific nannies that helped me do that, helped with driving kids to school, picking them up. Those times may not be as important for you to spend time with your family. So hire out. Don't feel guilty about hiring a bunch of people to do a lot of things for you so you can have more quality experience with your kids.
So you're coming back to Houston. Randy's got a job in MD Anderson, and Danny Jones hires you back. And that is where we, in what year is that?
2003.
Okay, so tell me about 2003 to 2005 or 6.
So I returned to Baylor and Texas Children's in 2003, pick up sort of my old job. But I was different. I had different experiences having been at Children's Hospital of Philadelphia. And there I was working in multidisciplinary teams, specifically one that managed patients with craniofacial malformations. It was a multidisciplinary approach to these kids with syndromic congenital facial deformities.
How did you get involved with that again?
The individual that had left CHOP, the pediatric ophthalmologist who was part of that service, part of that multidisciplinary team, had left, and they needed someone to fulfill that position as an ophthalmology representative for this team. So as he exited, I was lucky enough to take up his position on that team, managing the ophthalmic abnormalities that occur frequently in these children, which stem from front of the eye problems, cornea problems, lazy eye or amblyopia. They have strange prescription issues and need glasses. They have often very unusual and complex eye misalignment, and also optic nerve problems that can lead to blindness. So I became the representative on that team. I had some experience from my first days at Texas Children's because Dr. Van Norden didn't want to be on that team anymore, craniofacial team at TCH. So whatever Dr. Van Norden wanted me to do, I did. And so I took over his position on that team, and that gave me some experiences that were valuable on the CHOPS craniofacial team. So I loved the multidisciplinary work. I learned so much about facial abnormalities and intracranial abnormalities in these kids that allowed me to take that information and teach pediatric ophthalmologists at our national meetings. I became sort of a thought content expert in this area. I loved that. The learning from others and taking that information and distributing it and passing it on to my pediatric ophthalmology colleagues, because these children are rare in most pediatric ophthalmology practices, but I was seeing so many because of the team and how the team attracted patients from all over the country and world. That was very exciting to me, very fulfilling. And when I got back to Baylor, those opportunities and Texas Children's in 2003, they weren't available. They were not offered to me or not available. And I got a bit, and also at Children's Hospital of Philadelphia, I worked alongside a very gifted, talented, incredible pediatric neuro-ophthalmologist. We shared a clinic day. His name is Grant Liu. And I learned a lot from him as well about pediatric neuro-ophthalmology. And I missed those experiences when I got back to Texas Children's and approached Danny Jones 2 years after I had returned and asked if I could do another fellowship in neuro-ophthalmology. And he agreed, as did the Texas Children's. They allowed me to spend a year with Rod Foroozan, the neuro-ophthalmologist at Baylor at the time. And strangely, Rod had been my resident at Wills Eye Hospital as a second year. And he was in my resident-run clinic on that Friday, and he wasn't crazy about kids, not comfortable around children. So I mentored him and helped him examine children and supported him. And he was the new neuro-ophthalmologist at Baylor. He had left his fellowship at Wills to become the neuro-ophthalmologist at Baylor, and he became my mentor for my fellowship. So I had been his mentor as a resident, and now he was now my teacher, and I was the student. So I'm like, 20 years older than him, 15 years older. But that year of being Dr. Foroozan's fellow was so pivotal. It was a renaissance. I was pretty despondent and burned out of practicing routine pediatric ophthalmology when I got back to Baylor. I was pretty burned out. And this fellowship, I didn't take call. I was a fellow. I put in eye drops. I did histories. I made phone calls for Dr. Foroozan and did the work of a fellow.
Just a pure neuro-ophthalmology fellowship.
Correct.
Adults. All ages.
He accepted children, not happily accepting young children because he wasn't really comfortable with the youngest. Like a lot of ophthalmologists are not comfortable seeing the youngest children. So that's where I was a bonus because I can take care of preemies and all ages of children. So he welcomed that. But yes, it was predominantly adult neuro-ophthalmology. We had some kids come through. I learned most of my pediatric neuro-ophthalmology on the job back at Texas Children's when I was their first pediatric neuro-ophthalmologist. But it was a terrific year. It was a renaissance year. I operated a little bit to keep my hand in surgery. I didn't want to lose my surgical skills, but it blew apart my career becoming a pediatric neuro-ophthalmologist.
How would you operate during a neuro-ophthalmology fellowship here?
I had 1 day a week of clinic back at Texas Children's or OR, or being in the operating room, so that I could maintain a clinic at Texas Children's and maintain my surgical skills.
So you were a 4 out of 5 day a week neuro-ophthalmology fellow and a 1 out of 5 work days pediatric ophthalmologist?
Correct.
Oh, I see. Very cool. And that's a 1-year fellowship?
Correct.
And then what happened after you finished your fellowship? Your second fellowship, I should say.
Yes, second fellowship. So back to Texas Children's as a full-time employed physician. And my practice diversified to become more pediatric neuro-ophthalmology. So I still maintained my eye misalignment surgeries, routine pediatric ophthalmology. Increasingly, I was seeing more and more adults with eye misalignment and also doing practicing pediatric neuro-ophthalmology, which was very important. And one of the very impactful events in my early career, the first time I was at Texas Children's, right after my pediatric ophthalmology fellowship, we we had a child, 11-year-old girl, who had had a heart transplant in early childhood, and she was on a lot of anti-rejection medications, and she developed a condition called pseudotumor cerebri, or idiopathic intracranial hypertension, and that is elevated pressure inside the brain without no tumors, but elevated pressure inside the brain that leads to optic nerve swelling. And it can be a blinding condition if not controlled. If the pressure is not decreased with medications or surgery, usually it's medications. If the optic nerves become swollen enough, the optic nerve can die and you can go blind. So this 11-year-old presented to us, and I was on the managing the consult service with Dr. Steinkoller, and we basically didn't know anything about how to manage her, and she went blind. In spite of our efforts, we had less than full complement of knowledge about how to manage this, at that time, very rare condition, not so rare now for a bunch of reasons, most of which we don't really understand why it's more prevalent now, but at that time, it was super rare. And that lack of knowledge that we did not have as pediatric ophthalmologists as how to care for that child, that was a very pivotal event for me, that we can do better. And joining Texas Children's for the second time, the neurosurgery team was exploding. They were the neuro-oncology team was increasing. We were seeing many more children with brain tumors that were visually impactful. And we can do better. So that compelled me to do the neuro-ophthalmology fellowship as well.
So now you finish your fellowship and you're doing pediatric neuro-ophthalmology at Baylor? Is that what happens?
Correct.
Okay, and that goes from when until when?
So I finished my fellowship in 2006, and now I return to Texas Children's and back to maintain my appointment at Baylor. Now I'm full-time pediatric ophthalmologist and pediatric neuro-ophthalmologist at Texas Children's, and I am promoted to associate professor and promoted to full professor in 2017. And we have 1 to 2 fellows every year. So these are ophthalmologists who've graduated from their residency and wish to pursue a subspecialty. I'm training fellows, as well as there's always a resident on our service, training residents in pediatric ophthalmology and neuro-ophthalmology, training them in the clinic and in surgery.
You're involved with the American Academy of Ophthalmology all throughout this time.
So my first, I think I was only 5 years out of my fellowship when I first became involved with the American Academy of Ophthalmology. I was asked to join a committee called the Lifelong Education for the Ophthalmologist Committee. And this committee created educational meetings at our American Academy of Ophthalmology annual meeting, the big meeting that happens once a year in the fall. My committee was responsible for subspecialty updates in all the subspecialties of ophthalmology. And so the committee was of about 10 people, and I was this junior baby person on the committee. After about 4 years on that committee, or 5, the chair of that committee had stepped down, and I was asked to chair and lead that committee. These subspecialty updates are the precursor to what is now Subspecialty Day at the AAO annual meeting, American Academy of Ophthalmology annual meeting. So it was the precursor. It was a very important job. It was a very popular educational event at the Academy, which happened, sessions were a day before the official academy began. And that was what gave me my entree into my volunteerism and participation in our terrific, amazing, huge 30,000 member professional organization of the American Academy of Ophthalmology. 94% of ophthalmologists in the U.S. are members of our academy. Most academies of medicine are not able to tout that high percentage of membership in their the practicing members in the U.S.
There's an ophthalmology department that's forming at the University of Texas at Austin Dell Medical School. How did you become aware of that department, and what piqued your curiosity in applying for the chair?
In 2017, or maybe it was 17, I was serving on the board for my subspecialty organization, which is called the American Association for Pediatric Ophthalmology and Strabismus. It goes by the acronym of APOS. And I was later president of that organization in 2020 during COVID. But in 2017, 18, I had heard via my position there that there was a chair position opening at a brand new medical school in Austin, Texas. I knew of Dell Medical School being a brand new medical school. Very, exciting that we have a medical school finally in Austin, Texas, associated with UT Austin. It was always amazing and not comprehensible why there hadn't been a medical school in Austin. But I heard about the chair, and I heard about it mainly through some colleagues who were applying for the position as chair. And some were pediatric ophthalmologists, many were chairs of departments of ophthalmology already. And I was certainly interested, but hearing about my competition and that I did not have the experience of being a chair of a department like these other colleagues who were applying for the position. I had never been director of a residency, which was also another leadership title that I felt was probably required to become a chair. Although I'd had these leadership positions within the American Academy of Ophthalmology and my subspecialty organization, I had never held what I felt were required positions to be a chair. And then hearing about the competition, other chairs applying for the job. So it was during the spring, probably, of 2018, I received a call from a friend who was a colleague of Dr. Army Harper's. Army is a famous retina surgeon here in town with Austin Retina Associates. And Army was on the search committee for this chair that I currently occupy. And he was having a beer with another retina colleague from Houston. And they were talking about the candidates that had applied for the position. And between Dr. Harper or his colleague, I'm not sure who came up with my name, but, she should apply. So I got a call that weekend while I'm at the Mid-Year Forum, which is a mid-year advocacy meeting for the American Academy of Ophthalmology in D.C. What do you think about applying for that job? Okay, now that I've been given the entree.
Who made the call?
David Brown, who is a retina surgeon.
Yes.
In Houston, Texas. Army did not know me at the time, so not comfortable calling me. Actually, it was a text. It wasn't even a call. It was a text. Someone on the search committee is interested in your applying for this position. Something like that. I submitted my resume or my CV next day on a Monday. Stuart Wolf, who was also on the search committee. He's a urologist at Dell Medical School. He accepted my CV and gave me the opportunity to apply for the position, which was a very unique kind of application process. And the problem was, within the next 10 days or so, the application process would close. So I had to get my ducks in a row and go through this interview process, which was actually a video recorded interview. I'm talking to myself, I'm reading the questions at the subject line and looking at my own computer screen and answering the questions. And make sure that you're in an environment where your Wi-Fi doesn't drop, because the entire interview will be erased and you'll have to start over. You can answer the questions a second time, but not a third time. Yeah, if you look like an idiot, you can have a repeat. I'm given a little bit of an information about what the questions are, but it's basically like, you know, I don't know what's going to be asked, and I have a time frame in which to answer. Like, there's a clock, you can't keep going on and on. So I go to my office at Texas Children's. I'm answering these questions. Their AC is off. I'm like sweating. And the first question, I'm able to view the recording, and I look like I have no synaptic delay, like I'm an idiot. I don't even look at the camera. My eyes are darting all over the place. I look like I have a schizoid personality. It was bad. So at least I get to repeat that one. And I got through the interview. I was told it would take about 45 minutes. It took about 3.5 hours, because I wanted to look somewhat intelligent in my answers and look at the camera. So that was the process, and the search committee got to review those. I think 10 applicants were reviewed, were allowed to interview in that format, and the search committee got to view those interviews like in their pajamas on 2 times speed. And I was selected for a face-to-face interview. 5 individuals were selected for a face-to-face interview on campus, but we were not allowed to meet with the dean. We all met with a group of individuals from the community. Mark Hernandez from Community Care Collaborative that oversees at the time, was integrated into the federally qualified health centers, individuals at Dell Medical School, and people in the search committee. Unfortunately, I didn't get to meet with you, except at dinner, where you're like 8 people over there. So that was a process. And then the dean asked that one candidate's name be delivered forward, and the group, the search committee, delivered my name. But the dean wanted a few more names. He didn't want just one name, I don't think. He got a few. 3 individuals interviewed with the dean on our phones or a laptop. My laptop connection didn't work, so I did it on my phone. It was difficult because I couldn't see him through my bifocal, and so I'm sure he looked up my nose the entire interview. Not a good look. Because my laptop didn't connect. And then I was asked to come back for a face-to-face interview, and I did not know I was the only candidate at that time. I met with other leaders at Dell Medical School, and my last interview was, I finally got to meet Dr. Clay Johnston, and he offered me the job.
Mm-hmm. Mm-hmm. Awesome. I didn't know all that story. And then you start, your first day as chair is in January 2018?
January 2018. January 16th, to be exact.
You were the only faculty member, right?
Only faculty member in the Department of Ophthalmology.
And so then what was how soon were you able to kind of get a feel for all the things that you were going to have to do once you started on the job?
Well, traditionally, medical schools, departments have three missions, three pillars: the three-legged stool of academic medicine, clinical care, education, and research. We have a fourth leg of our stool, and that is called Healthscape, and it is community outreach and intent to heal a community, care for patients in a community outside the clinic walls, a community engagement component. So as I sat down to wrap my head around how to start, I hired Nicole Groot, my wonderful executive assistant, and then hired a department administrator, which we call at Dell Med senior directors. And these were national searches for the senior director. And an individual I had known since 1986 applied for the job. And that was Randy Shepard, who was the department administrator when I was a resident at Baylor and a young faculty member. So Randy Shepard applied for the position. He had 40 plus years of experience in academic and private practice ophthalmology, had already a relationship with me beginning in 1986, and he was the clear-cut leader of the applicants for that position, hired Randy. He started about 6 months after I had landed at Dell Med, and he and I started to make plans for building the clinic, building a pro forma, a business plan to present for the building of the clinic and the health transformation building, designing that, getting procurement of purchase orders and the arrangements for the financing for all of the expensive equipment we have in ophthalmology in every single exam room, and the posting positions and making arrangements to hire regular core faculty. Concurrently with this, I am continuing medical education series for the community, which is expanded to about 300 participants, up to 300 invites go out for our CME virtual visiting professors and live visiting professors. That was part of my intent to show our community that I'm not a threat, that the department is not a threat. The department intends to be inclusive with a very robust ophthalmology community that was here in private practice and taking care of all manner of complicated disease and doing a great job. So I think the slow startup of the department in a way was beneficial for my introduction into the community, to not be threatening, to not be annoying, but to be like helpful. And here's free educational experiences that I can offer that come out of my budget, and just being very collegial and open, and how can I help without being a threat. So there was the other piece of the educational mission was developing a residency, and that was laid out in your and Mitchel's gift agreement, and Betty and Rose's. Your intent, one of the ultimate spirits of the gift was to create a world-class residency. And so I took that to heart, as that is a primary mission amongst many others. So these things are happening concurrently, and as I am assessing the Austin environment, what subspecialists are missing here, what subspecialists are not missing, but in high demand, but in low quantity, and that would be neuro-ophthalmology. Glaucoma was also, my colleagues in glaucoma here in the community were oversubscribed, needing more glaucoma support and specialists in Austin. And also with the urgency of getting everything together for the residency, hiring individuals in those subspecialty areas to help the community of Austin. One of my missions was to have no patient have to travel to Houston or Dallas for subspecialty ophthalmic care, to hire hire subspecialists so that that never happened. Missing subspecialists. Also, hiring faculty who are committed to the education of residents and medical students, but very specifically residents. And as we know, our faculty in our training, they sat with us and guided us through a cataract surgery, up to 200 cataract procedures, because that's the primary procedure for a comprehensive ophthalmologist, and we want our learners to have, our residents to have the faculty who will supervise those experiences to create, at the end of their training, a safe and talented intraocular surgeon. So that was also a primary goal in recruiting the faculty with an eye to educating residents in intraocular surgery. And a passion to do that, and a passion and commitment to raising up leaders in our field. So with those things in mind, I set out to recruit and hire a group of mission and culturally aligned individuals that would be pioneers with me to start something new. So when I was looking at the position of chair, I took the opportunity to see what Clay Johnston, our inaugural dean, was about. What was this brand new medical school? How is it unique? And why was it getting such great press? First of all, the class is only 50 students a year. And the dean's inspirational, aspirational ideas of rethinking everything we do in medicine, rethinking education, how we deliver education, how we interact with learners, residents, medical students, how we can improve the patient experience, how we can improve healthcare delivery with an eye to value, what's cost effective with higher biologic and patient outcomes. All of these things, and deconstructing how physicians are increasingly just work units and commodities and how much revenue we're generating. I would become very disillusioned with how organized medicine is progressing, and to hear Clay Johnston's vision was mind-blowing and very inspirational. So my faculty, they have to be pioneers, sort of like Clay Johnston and like all the other chairs, like myself, willing to come into a brand new organization without a huge track record, but with such incredible promise and with such incredible goals and vision. And that takes a special individual to come to some place that's unfounded. There has to be great trust in me and great trust in the faculty member. So I spent a lot of time developing relationships with those that I was recruiting and who were interviewing for the positions, because it takes a special person to come somewhere brand new. We have to work so cohesively and be like-minded and all be pointing toward the same North Star. And I've been lucky enough to recruit and hire faculty that fit all of those, check all those boxes, bring subspecialties to Austin that aren't represented here, individuals that work synergistically, that like hanging out together after hours and during work hours, that enjoy being with residents and miss the resident opportunity experience before we had the residency approved. So it's been my greatest pride, my faculty and how they interact, and the joyful place that the clinic is with our staff, and where we're headed.
So today we have how many faculty total? Full-time faculty.
Full-time Dell Medical School employed faculty, 4, including myself.
It'd be Eileen Bowden, glaucoma.
Jean Kim, who is cornea, and our program director for the residency. Eileen's glaucoma trained, and she is director of the medical student education and associate program director for the residency. Eric Kroll, who serves as our medical director, who oversees the clinical enterprise at UT Health Austin, which is the physician practice affiliated with Dell Med. He oversees the clinic, and he's uveitis trained. And then Harry Ong, he's MD, PhD, and he's neurology trained neuro-ophthalmologist.
And so if there are medical students looking at our program, what should they know? What would you want them to know about where we are, and now they know where how we started? What would you want them to know about what we're about now and where we're going over the next 5 years?
So training residents, as you've heard, is my passion and a primary goal I had taking the job. We've now gotten the residency approved and up and running. We're now recruiting for our second class of residents. And so as I talk to them on their Zoom interviews for the residency, I tell them that our department, I describe the collegiality. I'm this bustling environment of our UT Health Austin clinic. I have a flattened leadership style so that I need my faculty to advise me on the new direction we should take and how we need to pivot. We are a startup, so if something's not working, it's not a failure. It's an opportunity to do something better. So I need their input to do that, and I want the residents' input to do that. So if we're going to rethink residency, it's not going to be the hierarchical, top-down sort of approach that I was raised in and trained in, that you were raised and trained in. The residents become part of the fabric of our department. They're learners, obviously, but I want to cherish them like junior faculty. Okay, so I have a resident that comes in who's interested in ocular pathology, super rare niche of ocular pathology. We don't have an ocular pathologist in Austin, Texas, or maybe even in Texas. We do have one in Houston, but a very niche interest. Okay, if you are interested in ocular pathology, you're going to be our champion, and you're going to be the liaison to the ocular pathologist who teaches you as residents remotely, because that's a requirement of a residency, as there's an ocular pathology education. So the residents have this significant increased opportunity to help shape the direction of the department. So a leadership opportunity already out of the gate. Another thing I tell medical students who are interested in our residency is that another huge reason I came to Dell Medical School, you've heard the innovation and the inclusivity into a community and how we rethink everything. But the other 50% of the reason that I was so interested in this position was the state of the care for the safety net population in ophthalmic conditions that was present at the time I was interviewing for the position. At the time, Dr. Briggs is an ophthalmologist. He was the only comprehensive ophthalmologist who was part of the hospital district contract. He did all the cataracts for the safety net population who were covered under the hospital district medical plan called MAP and MAP Basic. When Brackenridge closed down, all of the intraocular surgery equipment got thrown away. They didn't want Dr. Briggs doing cataracts in an inpatient operating room. So Dr. Briggs had to find an ambulatory surgical center to perform cataract surgery. And it took 6 months or so to find an ambulatory surgical center, ASC, that would accept the hospital district contract, which is obviously not a high-paying contract, so that he could perform cataract surgery on these individuals. By the time he finally got a contract at an ASC to perform the surgeries there was over 300 patients on a waiting list to get their cataracts removed. Individuals whose quality of life were just on hold because they couldn't see, because Dr. Briggs couldn't get an operating room. That situation, that catapulted my interest and commitment to getting this job and fixing that problem. That is unacceptable. For the most liberal city in Texas, our capital, to have that situation exist, that we are caring so poorly for our poor and vulnerable, unacceptable. And that's the other part of my mission, is we take care of these patients with equal respect and dignity. They come into our clinic. Regardless of their insurance plan and their backgrounds, everyone's in our clinic together. Residents and faculty are seeing these patients in the same clinical space. It's not a county hospital where they're separated from the attending physicians. All patients come into our clinic. They're all cared for in the same high-quality manner by our faculty and now the residents. So my mission is also to train residents to be committed and socially conscious and always have some part of their clinical efforts giving back. Charity care or Medicaid patients or patients with these lower paying insurance plans to be engaged, socially conscious, and healing a community, not just those who can afford the care.
Or if a medical student anywhere in the United States is interested in our program here in ophthalmology, why would you say they should choose our program over another program?
So the experience that we will offer here is going to be very much different in several ways compared to the way I was trained, where the faculty are here and the residents are somewhere down here, and there's this big disconnect, schism, and you don't email or you don't text your faculty unless it's absolutely necessary and you're a little bit afraid of them. This is a very collegial faculty, and the residents are more on a similar organizational chart level, if you will, such that friendship and connection and harmonious relationship without the steep hierarchy, it allows for such better learning and training. There's none of that intimidation that I'm going to ask a stupid question. Like, there's no stupid questions. Of course there were. I mean, we grew up when we were impugned for asking stupid questions. But our faculty being small and so cohesive and collaborative, I can see that happening with the learners. Our first set of residents are just so much more free to ask questions and to get help, because it's more of a customized learning. You don't know about this, I'm going to teach it to you. It's more one-on-one interaction in a more friendly, collaborative environment compared to legacy programs and compared to previous paradigms of how we train residents, certainly from where I came from, rethinking how we educate residents. Another unique differentiator for our department is our alignment and affiliation and integration with UT Austin. So when Dell Med first landed, I think that the scientists on UT campus and the professors were like, who are they? We work 9 months a year. We ascend the academic ladder by getting grants and teaching evaluations. Those guys, those docs, they make a lot of money. They work 12 months a year. They don't have Christmas they don't take off on Christmas. They're on call. There was a lot of uncertainty about at the professor level, I believe, and non-understanding of who we are as a medical school. But over these years that I've been here, there has been a much greater connection and integration with UT Austin. And here's like one story. A few weeks ago, Dr. Rylander, who is also an ophthalmologist in town and also a professor of biomedical...
Which one, Grady or Gary?
Grady.
Grady.
Professor of biomedical engineering, emails me. We have 4 students in BME. I'm not sure if they're graduate students or undergrads who would like to free think with your faculty about innovations in technology. What devices can we develop together? So, about a year ago, Jean Kim and Eileen Bowden and our resident, Armin Mosina, met with a BME biomedical engineering grad student, and they're developing a brand new glaucoma filtering device. That's what's so amazing about being part of UT Austin. And it's these opportunities that have been embedded in the residency, the 4 years that they're with us, research time so that they can explore these opportunities on campus. Plus, because we have so many opportunities that need to be fleshed out and developed. And this, like I said, I think the residents are going to be like junior faculty. Somebody interested in ocular pathology, great. You're going to be our liaison to the ocular pathologists that we're going to engage. Resident that may be interested in, what was the other, global experience. 80% of residents are interested in an international experience during their residency. So these things that more established departments have got these relationships already figured out. I have a brand new faculty. We've been building a clinical enterprise and also getting the residency going. We haven't had the bandwidth to do that. We have a resident who wants to spearhead that. I'm going to give you the support, time to do that, support to do that, financial backing, and let's get it going. We've got a relationship. Dell Medical School has a relationship in Kenya, organization called AMPATH, or a medical facility called AMPATH, and then an emerging one in Puebla, Mexico. So yeah, you want to do that, that's what you do. And I'm going to give you the support to do that. So it's those unique opportunities that are just not clearly not available in big, giant, legacy departments of ophthalmology that are available here.
And then, do you foresee adding additional faculty over the next few years? Yes.
So fiscal year 23 for us begins September 1st. That's when the academic year of UT Austin begins. My intent is to hire 2 more faculty in that year and 2 more faculty after that, and putting more emphasis on hiring a clinician scientist to spearhead our research program, although it's already often running right now. We've had many publications with medical students. We will with our residents. We've also have enrolled in 2 clinical trials with 8 on deck. So we are getting more engaged in clinical research and scholarly work with our learners right now, medical students, and in the future with the residents. But somebody that has maybe a focus of tech transfer research, translational research, brings an individual like that into the department.
Mm-hmm. What's it going to be like as president-elect, and then what do you foresee during it's a 1-year term for AAO, American Academy of Ophthalmology president, which starts in January 2024. Is that correct?
Yes. President-elect begins in January 2023, and president year begins January 2024.
So what do you do as president-elect?
I'll attend the board meetings for the Academy. These board meetings happen about 4 times a year, attend the mid-year forum, get involved in certain committees that the president-elect is expected to participate in. I will have executive meetings with Stephen McLeod, who is our president and CEO of the Academy, the current president, monthly. Also, those meetings are attended by the past president, who would be Bob Wiggins, and the current president, Dan Bryceland. So we'll be huddling about major issues that are affecting the Academy with Stephen on a monthly basis. With in my president year, significant increase in trips away and committee oversight and representation, representing the American Academy of Ophthalmology at subspecialty meetings, international meetings.
So what are the biggest issues confronting people who are considering ophthalmology or who are practicing ophthalmology as a specialty today and over the next few years?
So I think every president brings their own initiatives and their pet interests, not so much pet interests, but they have their own unique backgrounds, and they see organized ophthalmology differently and see different problems, and they bring those problems and potential cures or solutions to those problems. And for me, my projects will be improving the impending workforce shortage, specifically in pediatric ophthalmology, neuro-ophthalmology, and in uveitis. So if you look at how many neuro-ophthalmology positions, fellowship positions fill, it is only a fraction of the complement of fellowships. And in pediatric ophthalmology, the same thing is happening. Uveitis is under-recognized. And also in future, there will be a future supply and workforce shortage. It's pretty drastic in pediatric ophthalmology. I know that best because that's my home turf, with maybe up to half the fellowships this year and last not filling. So if that is not addressed in about 20 years, there will be half of us have retired, and the remaining half, there will not be enough pediatric ophthalmologists to care for our children. So I have a commitment and passion for addressing that at the academy level, and what can we do to stem that tide and to improve maybe reimbursements for pediatric ophthalmology procedures. They've been cut by the Medicare and CMS. They've got those cuts will go into effect next year, 20% cuts for all of our surgical codes. What can we can't walk that back, but how can we improve reimbursements and payments to pediatric ophthalmologists? Because when there's a pay cut, that certainly doesn't compel people to go into a specialty. Comprehensive ophthalmologists have been suffering this decline in reimbursements for cataract surgery, the bread and butter procedure, ever since the inception of the DRG and CPT code payments. We've been suffering that loss, so that's always a priority issue for every president, as it will be for me. But these are other niche interests for me, is the workforce shortage in those specialties. Also, engagement in care for the indigent and the safety net population. How can we facilitate that at the academy level, get comprehensive ophthalmologists, improved care for the poor and vulnerable, maybe within the federally qualified health centers, maybe make an algorithm and a workbook and how our community ophthalmologists can get involved in improving the care of the patients who can't afford commercial insurance.
So let's dig a little bit into, let's say, strabismus surgery. Over the past 20 years, has reimbursement for a pediatric ophthalmologist doing strabismus surgery, has it steadily declined or remained flat, or has it gone up and down over that 20-year span?
All right. So in terms of payments for strabismus surgery, we have in pediatric ophthalmology and those who perform strabismus surgery, those payments had not been re-evaluated for decades. Unlike cataract surgery codes that seem to get re-evaluated by the RUC, which is the Relative Value Scale
Update Committee.
Relative Value Scale Update Committee, called the RUC. Thanks to God, there's an acronym. So the RUC seems to, every 2 years or so, reevaluates glaucoma surgery codes and cataract surgery codes and decreases reimbursement for them. There's rarely an uptick in the reimbursements. If there is an increase in reimbursement, it typically has gone in the past to outpatient codes for primary care docs to compel people to go into primary care, which was in a workforce shortage. So because it's an equal sum game, the government, if it wants to bolster up one code, it takes from another code. So cataract codes, glaucoma surgery codes, many of the ophthalmology surgery codes have gone down over time, but pediatric ophthalmology, strabismus codes have not been touched in 2 decades until my presidency of APOS, when we were told that the strabismus codes were getting reevaluated by the RUC, and those are the primary surgeries that pediatric ophthalmologists perform, and that we were going to likely get a cut, which we did. So in 2024, I believe, or 23, there'll be a 20% cut across the board to all of our surgery codes. Strabismus surgery codes.
How's that ever gonna... So people go where they're going to be compensated, and if the compensation pie is shrinking, people won't go there. So how will that ever get... How will the pendulum ever swing back toward some incentivization of somebody becoming a pediatric ophthalmologist?
So there's been discussion. I was on a task force about this within APOS. The task force was specifically aimed at, should we hire a lobbyist to help us at the federal level, possibly 50 state level, to improve reimbursements for pediatric ophthalmologists. We can't walk back the RUC decision for the 20% cut for strabismus surgery codes, but could we address it at a Medicaid level, that we are caring for children and that requires more time? Our surgeries require 2-3 times more time than a cataract surgeon can perform their procedures. We've got the pre-op, the kid goes under general anesthesia, there's a lot more time. Maybe we can address this with Medicaid. Medicaid is administered, much of it is administered at a state level, so we have 50 states, which sounds inordinately difficult, but that is one idea, is to approach it that way. Also to incent residents to pursue pediatric ophthalmology by providing stipends from our professional organization for cost of living, entice them through their residency by sending them to our national annual meeting, subsidizing that. As we know, we have to make a living. We need to make a decent salary to pay off expenses. Most medical students come out of residency with up to $200,000 in debt. So we don't want such poor salaries or disparities in salaries between subspecialties in ophthalmology, because our residents will go into another specialty and ignore pediatric ophthalmology, say. But I think this generation is less fiscally minded and has more of a mind to work-life, maybe not so much work-life balance, but how more about emotions and passion about what you do, and if it's fulfilling, not just your bank account fulfilling, but fulfilling you spiritually, fulfilling your soul. What makes you happy? I think especially maybe post-COVID, people are thinking more about what fulfills them and not just what makes money. So giving residents more of an experience in pediatric ophthalmology early on, hopefully they'll see how awesome our subspecialty is and compel them to pursue pediatric ophthalmology so we don't face this impending horrible workforce shortage.
Let's talk about women in medicine.
I liked your question, can you have it all?
Yeah, okay, yeah. Let's talk about women in medicine. If you're talking to the University of Texas sophomore or any college student who is considering a career in medicine which would require them to go through college, medical school, residency training, and then come out on the other end at about the age of 30, what is your advice to them, and can they truly have it all?
All comers that are interested in medicine, or women?
All comers, but you can speak to it from your perspective as a woman who's been through it all.
I think I can speak to it. When I came into medicine, we were definitely in the minority. And we have a lot of people applying into medicine who are also in the minority, underrepresented minorities in medicine, but also first-generation Americans. Nobody in the families graduated from college except this individual. So coming out of a background where your parents weren't both doctors, or you didn't come out of an affluent, you had to work through college, or you were in the minority of people that are pursuing medicine in general. For me, that was women in my day, not so much now because it's 50% women. But I think I can speak to those groups that are in the minority. And that is, medicine is a lot of hard work. Getting through medical school, getting into medical school without the support and understanding of your family takes a lot of perseverance and tenacity, probably more so than the student that has a bunch of doctors in their family that has no problem paying for their medical school. But in the end, I think if you speak to any physician, it's the best job on the planet. We are given the honor of patients coming into our exam rooms, closing the door, and telling us everything about what ails them and what makes them afraid, and for us, the fear of blindness, or my child is going to be blind or can't drive. Who gets that opportunity to, who has that privilege? Not many people are given that privilege on walking into a room meeting a stranger. That's probably one of the biggest privileges that we experience as physicians. And if you don't have that support in your family and all the hard work it takes and all the financial burden that it may be, will certainly pay off in the end. But it's a lonely path. It was lonely for me because I didn't have a lot of women around to talk to. And we feel more comfortable talking with people that have similar experiences. So were there many women in the faculty? Were there many female medical students or people that had come before me? No. So that's a lonely place. But obviously, from what I'm saying and from your passion in medicine, Shannon, the road is certainly worth all the turmoil and difficulty getting there, but a lonely road at times. I think I'm...
I think you addressed it earlier. How do you balance things? You just prioritize what you think you should do at the phase of your life where you need to prioritize things.
Correct. But unlike...
And kids come once, and
that is correct.
You prioritize them while they're younger, and then as they grow older, the time available can be reallocated because your kids are doing other things. They're more independent.
Another phenomena I've seen is that women enter medicine, have a bunch of babies, have children, sometimes leave the workforce altogether or go part-time, but they never return. That's not right. That our society has invested so much in every single medical student, certainly the state medical student. How many state dollars go into every student who is at a state-run, supported medical student? It is gigantic. 5, 6, 7 times more than their tuition. And there's no requirement to stay in state, right? You can go anywhere. You can go to Dell Medical School and go practice in Rhode Island. It's also shocking that there is no contract like we paid for you, pal, to attend medical school. The state has subsidized, and you can just go anywhere in the world and anywhere in the country and practice medicine. That's pretty shocking to me. Fortunately, most people who train in a state stay in that state, either medical school training and residency training. They tend to stay where they trained. And in Texas, we're probably on the leaderboard for keeping people in state. So thinking about what our oath to patients, that we underwent this strenuous training, costly for the state, costly for the individual, and to leave the workforce or not participate full-time to return to a full-time job, which some, especially women, after the kids have gotten into high school and they're not at home as much, they don't return. I think that societally, that is unjust and unfair, and we have an obligation, a societal obligation, an obligation to our state that subsidized us. And I love your quote that we've had resident applicants ask why you and Mitchel donated $20 million to begin the department. And I know I'm not going to hack up. You're more eloquent with this quote, but those that have been given so much should return the favor and return some of those riches. They have an obligation to give back those who'd been given so much, like we have. Our training, our privilege to take care of patients, that's regardless of income. What an amazing honor and privilege that we should have a commitment to giving back. So I think of that when people leave the workforce for extended, don't return to the workforce after they've taken care of their kids, when they're not in the house anymore or they're at school all day. They need to come back and give back and not continue part-time. That's one of my other comments I make to women in medicine, to implore them to not stay part-time forever. But there's a time and season for everything, and kids, as you point out, they're young only once, and that's such an important, rich time for them, for the parent, and that can never be recaptured if lost.
Thank you, Jane, for sharing your story and your experience.
Yeah.
And I hope others will find it useful, and they'll learn from your path, and it may help them in their future going forward.
Thank you, Shannon, for the privilege and honor to be here. So I really appreciate you.
All right.